C is for controlling hemorrhage, and then we have to recognize other injury. After we do these four steps, we have to consider foreign body removal if it's necessary, and we have to repair the facial wound. A long time ago, the traditional treatment of polyp was toward the initial debridement, okay, and with the closure of soft tissue, but with no replacement of moist bone. This method will result in a scar contracture and substandard functional and cosmetic end result. Whereas nowadays, this trend has changed toward the immediate reconstruction. Actually, this change just happened because of the raised use of vascularized free tissue. So nowadays we are very familiar with the use of vascularized free tissue. This method, which is the immediate reconstruction, will result in less scar formation and less scar contracture. I will present with you my case report, which related to a 28-year-old patient who is medical free, surgical free, presented with a polyp injury to his face in September 2019 during a fight with unknown distance. Actually, the polyp entered the left side of his nose near the left alar cartilage, and this polyp did not exit. I will show you the picture of the site of the injury. Here is the site of the injury. It's marked as a scar. And as I said, this polyp did not exit. Okay. So he came to the ER. He was fully conscious, well oriented to time, place, and person. At that time, we did for him a CT scan, a sinus CT scan, and that sinus CT scan revealed the position of the polyp, which was in the nasopharyngeal space at the right parapharyngeal space, just 3 millimeter anterior lateral to the first vertebral body. I will show you his CT scan. Here his CT scan. This is axial CT scan. Okay, as we can see, the reflection of the polyps. Okay, and here maybe this CT scan is more clearer. So this polyp is just 3 millimeter anterior to the second vertebral body. Okay, and here other view. It's a coronal view for the polyp. And here is the sagittal view, which revealed the position of the polyp as I said, 3 millimeter anterior to the second vertebral body. At initial presentation, the patient had minimal bleeding and minimal epistaxis, which controlled by just simple dressing. And the cut wound, which is related to the side of entry, it was left for secondary intention, and the patient discharged. He was admitted for 1 day, and the next day he was discharged. The doctor decided at that time to keep the pellet in its place, as they thought that it will not cause any problem for him. After 2 months duration, the patient referred to ENT clinic. He came back to the ER with the complaints of throat pain, neck pain, foreign body sensation, and throat. So he referred to ENT clinic at Queen Alia Military Hospital. Okay, and our consultants, Dr. Qais Shfout, decided to perform a transnasal endoscopic removal of this polyp. At that time, when we saw the patient, he had a scar, as I showed you before, the position of the scar, which he already had. And there was a posterior small septal perforation. I will show you the perforation. Here is the perforation. And there was adhesion, maybe it's not clear in this picture, between the septum and the inferior terpinates. And we did for him another CT scan. The CT scan revealed the same position of the polyp. Okay. So as I said, Dr. Qais Shfout did for him transnasal endoscopic removal with the use of navigation protocol and fluoroscopy. For who doesn't know the navigation protocol, it's a protocol in order to know the exact location of the instrument which you used inside the nose. So we just download the CT scan on the computer, and then it tells us the position of our instruments. Okay, and it's very useful protocol. The fluoroscopy, it's the use of frequent X-ray in order to know the exact location of the polyp. So by using these two protocols, Dr. Qais removed the polyp without any complication and without any incision by just a transnasal endoscopic approach. And at the end of the operation, bilateral nasal pack were applied. I will show you the polyp, which is here. Here is the polyp. It's about 1 centimeter by 1 centimeter. Okay. The pack were applied for about 24 hours, and the patient kept in hospital for about 2 days for observation. During hospitalization, there were no any complication. I will talk briefly about the anatomy of the nasopharynx. So here is the nasopharynx. The nasopharynx is bounded anteriorly by the nose, inferiorly by the oropharynx, superiorly by the skull base and the sphenoidal sinus, and posteriorly is the first 2 vertebrae of cervical vertebra. And laterally, there is a space which is called parapharyngeal space. In this space, there is which we call the Eustachian tube, which an opening, it's a canal that connects between the nasopharynx and the middle ear. This opening, okay, will form a protrusion just lateral to the opening, will form a protrusion which we call the torus tubaris. Okay. It's very important actually when we operate in the nasopharynx. Here is the nasopharynx. Okay. When we do the operation in this space, we have to consider the position of internal carotid artery, which is just lateral and posterior to the torus tubaris. Okay. So according to this image, if we can imagine the position of the bullet, maybe it will be here, okay. So you can, if it's here, you can imagine how the bullet was close to the internal carotid artery and how it was close to the cervical vertebra, the body of cervical vertebra. Actually, bullet injury in the craniofacial region may cause damage to vital structure, and this may cause irreversible and uncompensated loss and fetal consequences. Unfortunately, the bullet's path is unpredictable. So the bullets can go in any direction and get lodged in any area of the skull. The most common area of its graft in general, facial foreign body, are the paranasal sinuses. A plain X-ray is useful in localizing palate, whereas compute tomography aids to pinpoint the actual site of the missile and provide the map for precious and safe endoscopic removal, as in our case. The site of foreign body would determine the approach for its removal. So sometimes the site is so critical that it contraindicates surgery, and the risk of its removal would outweigh the benefit. So the decision to remove, whether to remove the palate or whether to keep the palate, depends on its location, experience, and the skill of the surgeon and facilities that is available. As I said before, that the patient underwent transnasal endoscopic procedure. If this procedure did not work, so we have to move into another method, which is open conventional method of removal. But this method would raise the risk of morbidity, scarring, and it will cause a lot of complication. In this case, as I said, the bullet was successfully removed by transnasal endoscopic approach. The other approach, if this method did not work, is transnasal oral palatal split. I just want to show you here. Okay. So transpalatal split is we reach the nasopharynx through the palate, okay, and this by doing a split inside the palate. But this may, as I said, will cause a lot of complication. One of the complications including the Pharyngeal Insufficiency, and this means that the nasopharyngeal isthmus is not working properly. So so more air will escape into the nasopharynx, and this will result in a hypernasal speech, and maybe the food will regurge from the oral pharynx into the nasopharynx. And thank you. Is there any question so far? إذا في حدا عنده أي سؤال بكتب لي إياه على الشات بوكس. في حدا عنده أي سؤال؟ في حدا عنده أي سؤال؟
دكتورة ورود يعطيكي ألف عافية.
الله يعافيك. الله يعافيك يا رب، الله يسعدك.
تخيل كل شيء واضح، يعطيكي العافية.
الله يعافيك يا رب. هلا في عندنا the next speaker will be دكتورة سوسن أبو زيد. دكتورة سوسن أبو زيد ENT specialist بالخدمات الطبية الملكية. دكتورة سوسن أبو زيد هي interested dizziness، فعملت تريننج بأمريكا سنة عن هذا الموضوع. هلا هي المسؤولة عن مركز الديزنس في الخدمات في المدينة الطبية. نرحب بالدكتورة سوسن أبو زيد. هلا نشوف يعني 5 دقائق بتبلش الدكتورة سوسن.
Start our talk about the relationship between benign paroxysmal positional vertigo and vitamin D deficiency. The benign paroxysmal positional vertigo is the most common cause of chronic vertigo. The patient presents with recurrent attacks of positional vertigo that lasts for seconds. It's related to different head movements. The patient may have associated nausea and vomiting in between the attacks. He may be normal or may have imbalance. The etiology, I will show you the cause of BPV. This is the anatomy of the inner ear. You can see the structures of the inner ear, the utricle and the saccule. These are the otolith organs and the 3 semicircular canals. These are the vestibular organs in the inner ear. The utricle contains the hair cells embedded in a gelatinous material, and above it there is a layer that contains otolith. These otolith are calcium carbonate crystals. These are normally present in the macula. This is called the macula in the utricle and in the saccule. They are not present in the semicircular canals. Due to an abnormal etiology, these crystals can move from the utricle and go to any of these semicircular canals. The most common site could be the posterior canal, mostly in 70 to 90% of the cases. In 10 to 20% of the cases, it may go to the horizontal canal, and in less than 1%, these crystals or the otolith organs can go to the superior or anterior canal. These crystals can be embedded in the fluid in the perilymph of the canals, or it could be here we call it canalithiasis, or these crystals can be stuck on the capula in the ampulla, and here we call it capulolithiasis. To diagnose BPV, we need to do Dix-Hallpike maneuver. So if the patient gives a history of BPV, we do Dix-Hallpike maneuver. I will show you how. And we see a typical nystagmus. By that, we can diagnose posterior canal BPV. and we can do a treatment that's Eppler's maneuver. For horizontal canal BPV, we diagnose it by supine roll test, and here we can see also typical types of nystagmus in which we can treat the BPV according to the type. If it was canalothiasis, we treat it by barbecue maneuver or Gaffoni maneuver. If it was capulothiasis, we do Kazani maneuver. In the anterior arm canalothiasis, we do Appiani maneuver. This is Dix-Hallpike maneuver. Here, we move the patient's head 45 degrees to the right, and then we let the head hang 30 degrees or extend the neck 30 degrees. And if you see typical nystagmus of certain characteristics, here you will diagnose posterior BPV. The nystagmus characteristic, the characteristics of the nystagmus in patients with posterior canal BPV is the presence of this nystagmus, these characteristics in a nystagmus in the Dix-Hallpike test. The first thing is a torsional upbeating geotropic nystagmus. It has latency. So usually you can wait up to 30 seconds until you see the nystagmus. It's not sustained, so it does not last for more than 1 minute. It's not persistent, and it's fatigable. When you repeat the test more than one time, the nystagmus decreases and the vertigo decreases, and there is reversal. Reversal means when the patient moves from the supine to the sit-in position, you will see the reversal of the nystagmus, in which it would become downbeaten, torsional downbeaten to the opposite side. Also, the most important characteristic is the association of vertigo. So the patient should have vertigo with this nystagmus. If the patient has this nystagmus without vertigo, usually this is not a peripheral cause. It could be a central cause. This is the nystagmus in a patient who has BPV. When we put him in the Dix-Hallpike position, now we will see an upbeaten torsional nystagmus. You see a torsional upbeating nystagmus, geotropic. This is on the right side. Is it clear? Okay, so if you see this type of nystagmus, here you know that the patient has posterior canal BPV with the characteristics that we talked about. So we will do the maneuver for the treatment of these crystals to return them from their location in the posterior arm or the ampullary arm of the posterior canal to the utricle. And that's why when the patient is in the sit-in position, you move his head 45 degrees and then 30 degrees down, you will see this nystagmus, and then you move the head 180 degrees to the opposite side. So you start 90 degrees to the other side. If you see it, this is Eppler's maneuver for the right posterior BPV. You move him then 90 degrees to the left side and then another 90 degrees down. So a total of 180 degrees to the opposite side. And as you see, the otoliths will move through the canal like this by gravity and by these head movements, and it will return back to the utricle. We can also do Simon's maneuver. Simon's maneuver and the side-lying maneuver. Here, the patient lies on the affected side. Let's suppose it's the right side here, and the head is up. Then you move him to the opposite side, and the nose is down. And by this, you repeat it many times, the crystals will return back to the normal position in the utricle. Now we finished the posterior canal BPV, the horizontal canal BPV. Here we do supine roll test to diagnose horizontal canal BPV. The patient lies in the supine position, and you move the head 90 degrees to the right and 90 degrees to the left, and you look for a nystagmus with special characteristics. To diagnose horizontal canal BPV, if you see bilateral geotropic nystagmus, which means that the nystagmus is present bilaterally in both positions in the supine roll test, and it's it beats towards the ground, the lowermost ear in both positions. Here you will have canal lithiasis, or the crystals, the otolith, are present in the posterior arm in the canal of the posterior of the horizontal canal. If the patient had bilateral apogeotropic nystagmus, in which the nystagmus in both positions, right and left, the fast component beats towards the ceiling or the uppermost ear. Here, this means that the patient has either capulolithiasis or anterior arm canalithiasis. The crystals are present in the anterior arm of the horizontal canal. Now, how to diagnose canalithiasis and how to diagnose the site of the lesion. When we do supine roll test, if the patient had bilateral nystagmus that is geotropic, it beats, the fast component beats towards the ground. You look at the site that has more intense nystagmus and more severe vertigo. At that site, the patient will have, it will be the involved site. The nystagmus is present on both positions, right and left, but the site that has more intense nystagmus and more severe symptoms, here it would be the involved site, right or left. That's in the case of the geotropic or canalithiasis type. This is a patient who has geotropic nystagmus. He's lying on the left side, and you can see a left-beaten nystagmus. He's on the left side, and the fast component of the nystagmus beats towards the ground. Okay, so when we diagnose the site, we will do barbecue maneuver for the treatment. Here, this is a barbecue maneuver that's done for a treatment of right canalithiasis in the horizontal canal. So the patient lies in from sitting to supine position. He starts from the right, then to the supine position, then to the left side, then to the prone position. He moves 270 degrees to the opposite side, and then he sits down. We can also do Gaffoni maneuver. Gaffoni maneuver, this is done for the right horizontal canal canalithiasis. You let the patient side lie on the opposite side. So if the affected ear is at the right, you let him lie on the left side and wait for 1 or 2 minutes, and then you turn his head down so the nose is facing the ground down, and you let him wait for 3 minutes, and then he stands up or sits up. And now, if the patient had bilateral apogeotropic nystagmus in the supine roll test in both positions, right and left, he has apogeotropic nystagmus, in which the fast component of the nystagmus in both positions beats towards the ceiling or to the uppermost ear. We want to decide the site of lesion. So the site of the lesion is the site that has less, it's opposite to the canalithiasis. The site of the lesion is the site that has less severe nystagmus and less severe vertigo. And by that, you will make sure that the patient has either capulolithiasis or anterior arm canalithiasis. If he had bilateral apogeotropic nystagmus, and then we decide the site that has less severe symptoms, we can treat it by doing Kazani maneuver. This patient has apogeotropic nystagmus. You can see the fast component beats upwards towards the ceiling. The treatment here is to do Kazani maneuver. The Kazani maneuver for capulolithiasis, if the patient has involvement of the right side, you let him lie on the same side, on the right side, and keep him for 1 minute on this side lying position. And after 1 or 2 minutes, you let him lie his nose down, turn his face down, and the nose goes towards the ground. And you keep him in that position for 2 minutes, and then he sits up. If a patient has horizontal canal, anterior arm canalithiasis, the crystals are present in the anterior arm of the horizontal canal. We diagnose that also by supine roll test, and he has bilateral apogeotropic nystagmus. The ear that's involved, as we said, is the ear that has less severe symptoms, less intense symptoms. And here the treatment is starting by Appiani maneuver. So I will show you Appiani maneuver. After we do Appiani maneuver, we will convert the crystals from the anterior arm to the posterior arm, or to the typical type of canalithiasis. And then we treat it as usual as the horizontal canal canalithiasis. This is Appiani maneuver. So let's suppose that the involved side is the left side. You let the patient side lie on the left side and keep him for 1 minute. And then you move the nose up. You move the head up. The nose would be up. And by that, the crystals will move from the anterior arm, as you see, to the posterior arm. They go down to the posterior arm. Here, you didn't treat the patient. You still need to do other maneuvers for the treatment of the canalithiasis of the posterior arm, like barbecue maneuver or Gaffoni maneuver. Anterior canal or superior canal BPV is a very rare form. It's 1% of the cases of BPV. It's very rare because if the presence of crystals in the anterior arm, in order for the crystals to go to the anterior canal, they need to go against gravity. And usually we can't see it in usual patients. Could be in the patients who play sports, who go upside down, so the crystals can go to the anterior canal. It's very rare. Here you diagnose it by Dix-Hallpike maneuver, and you will see a torsional downbeating nystagmus. Once you diagnose posterior canal BPV, you will do either reverse Epley maneuver or Yakavi maneuver. If the patient didn't respond to these treatments, of course, downbeating nystagmus needs investigations. The patients will need MRI and work up to rule out central causes. This is Yakavi maneuver. It's done for both sides, right or left. So you don't have to decide the site of involvement here. You let the patient from a sit-in to supine position and then hang his head 60 degrees down. So the crystals here will move from the anterior arm of the anterior canal, and then they will go to this most dependent area. And then you turn the head up. So you do flexion of the neck. You let the chin come on the chest. Here, the crystals will return to the utricle. So these are the types and presentation of BPV. Now, what are the causes of BPV? We can divide BPV into two types, primary or secondary. Most of the cases, BPV is primary, idiopathic. We don't know the cause. It's usually more common in older populations, but we don't know the exact etiology. The BPV could be secondary. It could be secondary to a head trauma. It could be secondary to vestibular neuritis. So they found that patients who have vestibular neuritis, after developing vestibular neuritis, they may develop BPV at the same involved site. And that's what we call Lancey-Hemingway syndrome, in which after vestibular neuritis, patients may develop BPV that may be due to degeneration of the utricle that will cause the crystals go and move towards the semicircular canals. Also, migraine can be an etiological factor. Patients with migraine may have compromise for the blood supply of the anterior, inferior cerebellar artery, or posterior inferior cerebellar artery, in which these patients, if they have compromise of the blood supply of the inner ear, that will make them more prone to have movement of the crystals towards the semicircular canals. Also, patients with Meniere's disease, due to the change in the hydrodynamics and the fluids in the inner ear, they may be more prone to have BPV. And the last thing that we talk about in our study is vitamin D deficiency. Vitamin D has a major role in the calcium metabolism in every part of the body. And the otolith organs, these crystals, the calcium carbonate crystals, have calcium as a major component of them. So the calcium metabolism the vitamin D has a very important role in this calcium metabolism. So patients who have vitamin D deficiency will have abnormality in the composition of these crystals. The calcium composition of them will be compromised, so they may be less, their weight may be less, and they will be more floating in the semicircular canals, and those patients will have higher risk to develop BPV. In our study, we found that patients with BPV have lower serum vitamin D levels. Also, the patients who have recurrence of BPV also have lower serum vitamin D levels. We tried to see if patients with bilateral BPV have lower levels, but we found that there is no significance in their, once we compared them with the control group. The last thing is the number of repositioning maneuvers that we need for patients with BPV. The ones who have low serum vitamin D levels needed more repositioning maneuvers, EPLIS or barbecue, or these maneuvers, we needed more than the patients who have normal serum vitamin D levels. So vitamin D has an important role. Patients with BPV, if they have recurrence, if they have, they need a large number of repositioning maneuvers to do, we need to check their vitamin D levels and treat them. And thank you.
يعطيكي ألف عافية دكتورة سوسن. حدا عنده سؤال للدكتورة سوسن أبو زيد؟
يعطيكم العافية جميعاً. يعطيك العافية دكتورة ورود، يعطيك العافية دكتورة سوسن.
الله يعافيك.
جهودكم مباركة وما شاء الله عنكم، الله يحماكم. وهيك بننهي سيشن ال ENT إن شاء الله، وحيكون بعده سيشن الأشعة بس على الساعة 5:30 إن شاء الله، على الساعة 5 عفواً.
يعطيكي ألف عافية.
بريك. الله يعافيكي.
يعطيك العافية.
الله يعافيكي، الله يسعدك.
Thank you.
أوكي. شكراً كثير دكتور.
أهلاً.
نروح ببريك صغير للساعة 5، يعني هو ساعة إلا ربع، وبنرد نرجع إن شاء الله على سيشن الأشعة اللي راح يبلش إن شاء الله على الساعة 5 المساء. يعطيكم ألف عافية وبنشكر حضوركم، ونشوفكم على خير إن شاء الله.
بنك الشفاء والصحة الأردني هو مؤسسة أردنية خيرية غير ربحية تعمل ضمن اختصاص وزارة الصحة، وتم إطلاقه رسميا في الأردن عام 2016، ويقدم بنك الشفاء خدماته الصحية بعدالة وكفاءة عالية للمواطنين والمقيمين في الأردن دون أي مقابل أو تمييز من الغير المؤمنين صحيا في أي جهة رسمية أو خاصة ولا يقدرون على دفع تكاليف علاجهم. يأتي بنك الشفاء والصحة الأردني على غرار بنوك الشفاء موجودة في عدة دول من العالم، والتي تعمل على تقديم الاحتياجات الأساسية والخاصة في المجال الصحي، وذلك لغير القادرين على توفيرها لأنفسهم ولذويهم بما يكفل الحفاظ على كرامتهم الإنسانية. ولذلك تم تأسيس بنك الشفاء في الأردن بهدف تقديم الرعاية الصحية الشاملة المجانية للأردنيين والمقيمين على الأراضي الأردنية من الفقراء والمحتاجين الغير القادرين على دفع تكاليف علاجهم. كما يهدف بنك الشفاء إلى ضمان الحد الأدنى للحماية من كافة الأمراض وتعزيز أنماط الحياة الصحية الإيجابية ضمن المعايير الدولية. كما يعمل بنك الشفاء على رفع مستوى الوعي الصحي لدى الأفراد من خلال عقد برامج ومشاريع توعوية وتثقيفية في مختلف المجالات الصحية. ويعمل بنك الشفاء أيضا على رفع قدرات ومهارات العاملين في القطاع الصحي في سبيل تحسين الخدمة الصحية التي يتلقاها الأفراد. ويرفع بنك الشفاء من خلال خدماته التي يقدمها شعاره الذي انطلق منه ويؤمن به، وهو الرعاية الصحية حق للجميع. وقد حقق بنك الشفاء وبفضل الله إنجازات مميزة خلال الأعوام الماضية في مختلف الجوانب التي تعزز منظومة الأمن الصحي في الأردن، حيث يبلغ عدد المستفيدين من خدمات بنك الشفاء بشكل مباشر من أصحاب الحاجة بشكل سنوي حوالي 1500 شخص، موزعون بين مواطنون أردنيون وجنسيات أخرى. وتتوزع الخدمات التي يقدمها بنك الشفاء بين إطلاق الأيام الطبية المجانية وحملات التبرع بالدم وتوزيع المعدات والأدوات الطبية وعقد المحاضرات التوعوية الصحية وإطلاق حملات خيرية، تم من خلال تقديم المعونات من ألبسة وغذاء للفقراء والمحتاجين المسجلين في قوائم بنك الشفاء. ويمتلك بنك الشفاء مركزا للعلاج الطبيعي في لواء الرصيفة يحمل اسم مركز بنك الشفاء للعلاج الطبيعي، تم ترخيصه رسميا حسب الأصول من قبل وزارة الصحة، ويقدم خدماته العلاجية للمحتاجين بشكل مجاني دون مقابل. ومنذ بدء أزمة كورونا في الأردن أخذ بنك الشفاء على عاتقه المساهمة في حماية الأردن والحفاظ عليه من هذه الشائحة التي اجتاحت العالم. فأطلق بنك الشفاء عددا من المبادرات والحملات والبرامج التي تنوعت ما بين التوعية وبين تقديم الخدمات الإنسانية لمختلف أطياف المجتمع الأردني. أدى ذلك إلى أن تشرفت إدارة بنك الشفاء أن كانت حاضرة في لقاء جلالة الملك عبد الله الثاني المعظم حفظه الله ورعاه وسمو ولي العهد مع عدد كبير من المؤسسات التي قدمت جهودا كبيرة وأعمالا استثنائية خلال أزمة كورونا، حيث قدمت إدارة بنك الشفاء ممثلة برئيس الهيئة الإداري السيد أشرف الكيلاني خلال اللقاء ملخصا عن أهم البرامج والمبادرات والحملات التي نفذها بنك الشفاء خلال الأزمة. ووقع بنك الشفاء عددا من مذكرات التعاون والتفاهم مع عدد من المؤسسات الوطنية والتعليمية، أهمها توقيع مذكرة التعاون مع مجلس الأعيان بهدف تنفيذ برامج صحية وتنموية مشتركة.